Thank you, everyone, for waking up early to join us for the 8th Annual Neuro Symposium. We look forward to this, and I've talked to a bunch of nurses and people on the floor who also look forward to this. So I think we have a pretty good lineup of talks for you this morning. Um, as per usual, the past couple of years, I take the first few minutes to kind of discuss where we are as a program and where things are hopefully headed. This slide we show this slide every year, but this kind of shows you from the inception of our stroke program to where we are now, how many strokes we see per year. So, for those of you who do not know, in LA County, we are probably top 3 in terms of all stroke volume. And, even this year, our numbers of strokes that includes ischemic stroke, TI, and intracerebral hemorrhages will be on par with the past couple of years. It's not necessarily a good thing to see so many strokes, but given the geographic area that we cover, we do see quite a bit. And obviously, the majority of this is ischemic stroke, but we are seeing an uptick in the amount of intracerebral hemorrhages. This slide kind of shows you if you're in the hospital, you are hearing stroke alert activations throughout the day. These are level 1, level 2 stroke alerts that we call from ER and triage. These are the numbers from the past few years, and this year so far, quarters 1 and 3. What you see here is that we are activating more and more stroke alerts. We went from 2021 to about 1,300 stroke alerts to about 17, almost 1,800 in 2022, and we're kind of on par to hit that number this year as well. As you can see, quarters 1 through 3, we already have 1,300. So we are actively working with ER and as a program in general to kind of improve the process of activating stroke alerts. Obviously, a lot of these alerts don't end up being stroke diagnoses. We're seeing a little bit of a reduction in the amount of stroke alerts that actually end up having stroke diagnoses. That includes ischemic stroke, intracerebral hemorrhage, subarachnoid hemorrhage, and TIA. So we had 44% of our stroke alert activations in 2021 actually end up being stroke diagnoses, and it's been reducing over the years. And we're calling a lot more, number one, because we don't want to miss anything. We never want to miss an opportunity to treat a stroke, but we are seeing quite a bit of stroke mimics. So we are trying to work with the ER to try to better streamline the process of activating these stroke alerts. At the bottom of the screen, you'll see the top 3 non-stroke diagnoses for stroke alerts are dizziness, syncope, vertigo, sepsis, and encephalopathy. So the tough part with most of these patients, specifically with dizziness, is that sometimes with posterior circulation stroke specifically, you will have dizziness, but then we also want to look for other symptoms, but sometimes it's hard to differentiate. So we are working on that, and we are actively changing our stroke alert process to kind of improve this. Again, not wanting to miss any strokes, however. And then again, this year so far, 37% of our stroke alerts have been treated with either IV thrombolytics or thrombectomy. This slide looks at thrombolysis treatments. And again, since 2021, just to remind everybody, we have started going fully towards tenecteplase as our thrombolytic of choice. We've been doing very well with the use of tenecteplase compared to alteplase prior. Again, tenecteplase is the genetically modified alteplase, and it has been proven to be non-inferior in terms of thrombolysis compared to alteplase. And when we look back at our data from 2021 to now, we also have shown that it is non-inferior and potentially even a little better in some cases, specifically large vessel occlusions. Anyways, these are the numbers of what we're doing in the past years and this year for total IV thrombolytics and thrombectomy. Now, one of the big things that we always strive to do is try to treat as soon as possible. Obviously, time is always brain, so we want to administer thrombolytics or transition patients to IR for thrombectomy as soon as possible. We've been measuring times and trying to get better, and we are getting better every year. This is specifically for 2023. You may want to focus on the bar towards the end, and I think that's olive. It looks olive green to you, but our goal is to give thrombolytics as soon as possible, barring any contraindications and clearly establishing last known well and being safe, getting our CTs and appropriate scans to be done prior to administration. So the first part is door to kneel less than 30, and we're getting much better over the past few years. Now we're achieving greater than 50% less than 30 minutes, which is really great. We're making huge strides to do better there. And most of our patients are really getting under that 45-minute window. Obviously, it used to be the golden hour of treating with thrombolytics and trying to get in less than 60 minutes, but now it's just getting thrombolytics in as soon as possible, because when we treat patients as soon as possible, they do better. So we are doing much, much better here, and we've been working pretty hard to get to these levels. And I think initially with tenecteplase, when we started, there was a little hesitation with the transition from TPA to tenecteplase, but we've been seeing much better times now, specifically over the past year. This shows the median arrival time to IV thrombolytics, and this will show you from 2021 to now where we are. Our median times have been reducing steadily, so we're making huge strides to get much better, and we are doing better. This is a slide that looks at door to puncture time for specifically thrombectomy. And this is a huge thing that we've been trying to change and push over the past few years, really. It's kind of been stagnant over the past few years. And we just had a Joint Commission survey the first quarter of this year. And we were really trying to focus on trying to get better about moving our patients from ER to IR in the appropriate cases. And if you could see, towards the end in quarters 2 and 3 of 2023, we've really reduced that door to puncture time quite a bit. So we're really proud of that, because while our goal is still 75 minutes, we were kind of stagnant over the past few years, kind of in the upper 90s, 100-minute range. But we're really making huge strides to get better, and we are doing better. So that's really a testament to our team, really teamwork with the ER, IR, and neurology. And we've been really pushing to make that better, and it's been proven to be getting much better as the quarters go on, so we should all be really proud of that. This is door to device. Again, similar trends we're seeing with improved times from door to device, trends of lower times. Again, goal is always to get better, and is 90 minutes. We are getting closer and closer to that, and again, this is because of the changes we've been making. In regards to those changes, we've been working on this for quite a while, but we really wanted to decrease that door to puncture time. It's been highlighted in our Joint Commission surveys, and it's been something we've been trying to work on for the past few years. These are some of the things that we've tried to do to implement these changes. So just over the past month, I believe, or past few weeks really, we're starting to use this application. It's an app on our phone called the Capture app to try to facilitate team communication from ER to neuro to IR, to communicate in this app and send messages to each other and update things. And we just started the process, but it's kind of exciting to see how technology is going to try to help get us to the point where we need to get to. So we just started that process. Obviously, we have always had the level 1, level 2 stroke alerts, and we've implemented the RACE protocols to try to identify large vessel occlusions specifically from pre-hospital alerts. And when we get those notifications, then we know that we potentially have a large vessel occlusion and may need IR. So as soon as the patient gets the CT and CT angiogram, if there is a large vessel occlusion, we're trying to push for them to move to IR as soon as possible. In regards to specifically imaging, we've been trying to reduce the timing of the imaging processes, and we've actually reduced the processing time for specifically CT perfusion scans from 12 minutes to 6 minutes. So these few minutes here and there definitely help. Time is always brain, and any minute or even a few seconds from improving that time to get the patient to IR is a benefit. So that I think has made a difference. And again, transporting patients directly from CT to IR, we've been focusing on that during the weekday day shifts to see how that helps, and that's made big changes in trying to get improved door to puncture and door to device times. We've also sent rendezvous times at 30 minutes from IR activation for the night shift and weekend teams. So we're really trying to make big changes to try to improve these times, and we're seeing those results as you can see in the slides previously, that we're getting much, much better times of door to puncture and door to device. And again, even simple things as just like having a supply cart handy to get patients prepped as soon as possible for the procedure. These simple things are making big changes and improvements in our time. So we're really working hard, and I really want to thank the ER nursing staff, our neuro teams, and IR teams for all working together to make these changes and implement them. This is a slide that kind of shows where our patients go from discharge to 1 year. MRS is the modified Rankin score. It's a measure of disability, and it measures disability 0 to 6. 0 is no disability, and 6, unfortunately, patients die. So our goals, and in all stroke trials, we always look at modified Rankin scores to achieve independence. And a modified Rankin score of 2 or less is always the goal, because that is technically modified independence. So this is a slide that looks at specifically intracranial hemorrhages for 2022, maybe 2023. This is quarters 1 through 3. But on discharge, 15% of our intracerebral hemorrhages have a modified Rankin of 2 or less. But we track our patients, and we keep we like to keep in touch with them to see how they're doing. And you can see up to a year out that 61% of these intracerebral hemorrhages actually achieve a modified Rankin score of 2 or less. So what you see on discharge may not be what happens, 90 days, 6 months, 1 year out. So these patients do end up doing fairly well, and the majority of these patients do achieve a modified independence level. And that may have a lot to do with things like getting rehab and things like that, or specific interventions and treatments, but we are seeing improvement in these patients from discharge to 1 year. This slide looks at modified Rankin score in patients who receive tenecteplase and who otherwise receive IR treatment with thrombectomy. 18% of our patients on discharge have a modified Rankin score of 2 or less, and 74% of these patients up to 6 months to 1 year are modified independent. So that's huge numbers. And this is what we've seen in trials from even back in the day in 1995, the original Alteplase TPA trial, that patients who receive treatment with thrombolytics or IR treatment do end up doing better than those that do not, even long term, and this kind of proves that as well. This is just specifically looking at TNK patients and patients that receive thrombolytics. And the cool thing here is that at 1 year, 88% of these patients who receive tenecteplase have a modified Rankin score of 2 or less, which is huge. These patients do better, can potentially return back to work or good function. This is less of a burden overall on patients and patients' family, of course, because the biggest thing with stroke is to obviously prevent significant disability and improve symptoms. So we're seeing a lot of improvement there. So this is it's really good to see that patients do well even 6 months to 1 year out, those who receive treatment. Okay, and this is the last slide. We've been doing really well over the past few years with our program, and it's really a team effort. This is just a small portion of the team that you see here, but this goes from ER to nurses everywhere on the tele units, ICU, IR, obviously all the medicine disciplines, radiology, ER, neurosurgery, neurology, and neuro-IR. Big team effort. We're really trying to make things better. The goal is always to get better, and we are still striving to get better with our tenecteplase and IR times. So, the goal is always to improve there. But again, if I had a wish list for what we get in 2024, I'm hoping for things like 24/7 MRI capability, more collaborative efforts with the whole team, all disciplines, hoping to get formal designation of our ICU 3 as a neuro ICU, and we'll really be kind of the only neuro ICU in this geographic distribution, which is huge. And the take home from all this is that we are a community hospital, but we see a large volume of strokes, and I think we are on par with the top of the top, and we always strive to be the best of the best, and I think we should all be proud of where we are as a team and as a hospital with what we do with stroke specifically. for our patients in the community, I think we really serve a huge purpose. So for everyone who's online, I think we've had a record-breaking number of registrants for this symposium. We're doing amazing, and we're going to continue to move in that direction. So with that being said, I think we'll move on to the next speaker, Dr. Sadana.